We have a nice little group.
Mm.
Okay, Kevin, did you want to wait a few more minutes or just go ahead?
What do we have? We have about 17 people. Yeah, for the sake of time, why don't we go ahead and get started?
Sure thing.
Dr. Chu,
Okay, so
Dr. Chu, if you want to go ahead and introduce yourself. You
Yes,
have a nice group of panelists here, so let's go ahead and get started.
absolutely. So my name is David Chu. I'm one of the fifth year residents here at Inova Fairfax. Thank you all, one, for having me and for taking the time to listen to me. I actually have two cases to present. One was on the flyer for penetrating trauma, but then the other one I'll kind of leave as anonymous, and it's unrelated just because I figured that might help with, spurring on some sort of discussion. I'm actually accompanied by Sarah O'Berry. She's one of our third year residents. She helped take part in actually both of these cases, but she's going to ideally present the second case, assuming that her service isn't on fire right now. Dr. Fraud is going to do her best to make it. Unfortunately, she was caught in a case, but she told me that she's going to do her best to make it as well. Alrighty, so give me 1 second here to go ahead and share my screen. Okay, and then hopefully you guys can see all that okay. Otherwise, let me know.
Yeah, if you can just put it in presentation view.
You got it. Perfect.
Yep.
Alrighty. And let me go ahead and minimize this so that way I don't have to. All right. So no disclosures financially on my end. All right. So the case presentation. 28-year-old female. She presents as a trauma full activation, otherwise code blue in other health systems, with multiple gunshot wounds, one to the chest or a few to the chest, a few to the abdomen, and to the bilateral lower extremities after a domestic dispute. On primary exam, she had agonal breathing, decreased breath sounds bilaterally. She was severely hypotensive to the 80s and tachycardic to the 120s. She was a GCS of 3, and she was hemorrhaging from multiple of those gunshot wounds in the chest as well as the abdomen. So based on where you're at, my first discussion point was how would you proceed with either intubation? Would you go for an ED thoracotomy or would you go for a robo in this situation?
okay, so let's first start with Dr. Calderon.
Yes.
I don't
Good
think you would
morning,
use
Dr. Rose.
Roboa. I'll start right there. I don't think you would use Roboa, but go ahead.
No, we don't have it. We have the
Yes.
training, but not the supplies. But a tough situation, multiple gunshot wounds, you don't know where the patient is bleeding from. Well, as the ATLS mandates, first thing to do is to stop external hemorrhage. You have to place of some of your med students place some compressions or tourniquets in the limbs that might be bleeding out and prepare before intubating the patient. Now we prioritize the sorry the circulation first, because if you try to put some 50 cents of Versed of any other relaxing farm uh, uh, medication to this patient, if the patient is going to crash, going to arrest. So please first stop external bleeding. Place a couple of IV access. If possible, you have it available. You can do a Riboa as long the main bleeding is not inside the chest. Um, Try to initiate your massive transfusion protocol and try to complete your primary survey with an ultrasound extended fast, trying to figure it out where the patient is bleeding from the abdomen, from the chest, and be ready to take this patient to the operating room. This patient belongs to the operating room. and that's fair enough. If you think your patient is about to arrest, you can request your material to your instrument for getting ready for the resuscitation thoracotomy. That's fair enough. Thank you.
Okay, Dr. Kassem, so I know it's early in the morning there, and if you weren't awake, a case like this would wake you right up. What would you do?
Yeah, you got that right, Dr. Zuntrack. I just woke up as well. It was a what shall I say? It was a quiet night. So this is the kind of case that separates men from the boys, like they say. I think if I was a resident or a junior staff member in a hospital, when something like this comes on, every sphincter in my body will be tightened. Not to mention the anxiety level will be very, very high. Not knowing what the bullet has done and where it has gone and the trajectory you don't know. The patient obviously is suffering from hypovolemic shock. That's what you have to consider to be number one problem. So according to ATLS, it is the exsanguination that needs to be stopped. So not knowing whether she's bleeding in the abdomen or in the chest, but if you are in an institution where you have the luxury of using Reboha, this may be the case where Reboha might come into play and save the day. Even that, I'm not very sure, because if she's bleeding into the chest and you put the Reboa in, and you're done. So what would be the safest thing to do in a case like this, where you can stop the bleed and then get the airway taken care of afterwards? I probably will go with the time tested method of doing a quick anterolateral thoracotomy and get the cross clamp in the aorta. That's what I would do. But even then, I'm not very sure.
Okay, so how about Dr. Epstein? Okay, I guess Dr. Epstein's not there. Dr. Frisbee.
Well, I appreciate all those comments, and you're probably correct. The first thing to do is stop that hypovolemia. But I don't know whether he's got a tension or what he's got. But if you have the opportunity, you either need a chest X-ray or you're going to have to put bilateral chest tubes in there, open up two large bore IVs, the massive transfusion protocol, and since his score is 3, he needs immediate intubation.
Okay, anything else, Dr. Frisbee?
At this point,
may I make a comment?
Sure.
I agree actually with Dr. Kasim. This is a case where several people need to be working at the same time if you're going to consider intubation, and Reboa takes some practice. So an anterolateral thoracotomy and a cross clamp and calling the OR, somebody else is calling the OR, and you're on your way, because even intubation could take more time than you want to spare as this patient crashes.
Okay, very good. And I'll just add a few comments. So knowing that this is Innova, Dr. Ferrata's institution and her department, if anyone had suggested intubating this patient immediately, she would send you an overnight call without your supper. So there you go. So don't even think it, and certainly don't suggest it. And in this case, I agree with all the comments. You have to find out where the patient is bleeding the most, where you have to stop the bleeding first. And I agree with Dr. Frisby, bilateral chest tubes, massive transfusion protocol, and the people that do the Reboa, if you can feel the pulse, you have ultrasound, probably the Reboa takes the same or less time than doing the thoracotomy. But I would put the bilateral chest tubes and then do a quick EFAST, look at the pericardium, look at the abdomen to see where most of the blood is coming from. If the patient continues to pour out blood from either chest, that would be where you would need to go first, assuming that the abdomen isn't getting distended with blood. So bilateral chest tubes, possibly femoral A-line, and Reboa, then off to the OR without delay. Okay, Dr. Chu, if you want to continue.
Yes, sir. So at this point, I said, blood pressure was in the 80s, proceeded to precipitously drop down to the 60s as well. And of course, we initiated MTP. Given the fact that this patient was about to, was on the way to arresting, and with the active hemorrhaging going on, we proceeded with an ED thoracotomy and evacuated 5 liters of blood from the chest. And of course, there was loss of vital signs upon opening. At that point, the aorta was cross-clamped, cardiac massage was initiated. Fortunately, we were able to get a return of spontaneous circulation, and that's when we subsequently went to the OR for further management. In the OR, what we found in the chest were lung injuries, specifically parenchymal, as well as some minor vessels. So a tracheotomy was performed; those vessels were oversewn. Pericardial window was performed, which was negative, but because there was hemorrhaging from the abdominal wounds as well, a midline laparotomy was made, where we noted injuries to the small bowel as well as the associated mesentery, as well as a left colonic injury that wasn't amenable to primary repair. So the involved segments of small bowel were resected, as well as the left colon was resected, left in discontinuity. There was a liver laceration that was amenable to packing, and so that was able to be controlled. And there, afterward, we placed an ephthera and took the patient back to the ICU for further resuscitation. So, in terms of the early post-operative course, she fortunately was able to be weaned off of pressors over the next couple of days to the point where she could undergo abdominal closure on hospital day 3. This involved an end ileostomy creation. And then on hospital day 7, she was actually able to be extubated to room air with all these things going on. So we thought, hey, maybe we're turning a corner. Unfortunately, on hospital day 8, she began to develop hypoxia, which worsened over the next 24 hours to the point of requiring reintubation. And despite being on 100% FiO2, she became much more hypoxic with a chest X-ray, as shown here. So my next question would be, how would you proceed from here?
Okay, so why don't we go to Dr. Epstein?
I would hope that you have respiratory therapy involved in working out the vent before you would go to ECMO. You didn't say how badly the FiO2, she was 100%, but what was her PO2?
Oh, her PO2 at this, yeah, I did not provide those lab values. I apologize. But her PO2, I think the easiest way would just to say the PDF ratio was essentially was at 70 at this point. She was on the classic ARDS protocol of 4 to 6 cc's per kilogram for tidal volumes. And then in terms of PEEP, we were going up to 8, but we didn't really want to go beyond that. And despite all of that and a FiO2 of 100%, she wasn't doing well.
Well, the problem, of course, going up in PEEP is you've repaired the lung,
Mm-hmm.
and then you have the problem of blowing out the lung. I personally don't have a ton of experience with ECMO, but it would seem that you're pretty close to it if not doing it.
Okay, so let's see, Dr. Frisby.
Yeah, I think he's got it. Frankly, I don't have any experience with ECMO at all, but it sounds like to me there's a whole team that has to be on this ECMO issue, and the time that it takes to do that. I'd certainly like to learn more about it, but ECMO seems like the way to do. At this point, if your FiO2 is 100% and you're still you've tried everything and your respiratory therapy sort of shrugging their shoulders, then it's time to go ECMO.
Okay, Dr. Calderon.
Well, nothing new to say. This is a very severe respiratory distress, and the patient needs the ECMO unit to be on touch with this. That's not, and that's not me. That's a special unit. If there is no cardiac failure, BB ECMO is what the patient needs, and I hope she gets better. If there is cardiac failure, is BA able what needs to be done.
Yes, okay. And then I assume, Dr. Chu, that the pulmonologists and critical care people also considered doing a bronchoscopy, bronchoalveolar lavage, removing plugs, getting good cultures, all of that. So they've done that, and she's still not doing well, right?
Yes, sir. And so
Okay.
a BAL was performed at that point.
Yeah. So you know, you're lucky you have the ECMO, and you know, it's not much of a decision. Your hand is forced here. But before you go on, let me just ask you. So when the patient came in, when did she get intubated? And where was the bleeding in 5 liters only from the parenchyma of the lung oozing that you stopped with a tracheotomy? That was all the 5 liters?
So when I said oozing, if I mentioned oozing, it was more of it was less like venous bleeding. There was arterial bleeding, but they were branches off of the pulmonary artery, but like pretty peripheral branches. So they were amenable to being oversown from there. Um, you know, the it's hard for me to describe without pictures, unfortunately, but it was enough for me to be able to say, okay, that's where that 5 liters came from.
Okay, and if you just put a chest tube in, you got 5 liters, you'd have to open the chest anyway. But do you think that would have stopped the bleeding, or you still would have to open the chest?
I would have opened the chest at that point just because of the fact that with the trajectory that patient was going on, and we were pretty quick and efficient in terms of getting those large bore IVs, but that pressure was dropping. If I think that patient was going to code at that point anyway, and we were going to go the way of ED thoracotomy regardless.
Okay, and when did she get intubated?
Simultaneously as we were opening, essentially, just because the GCS was 3 and we were just on at that point trying to get in. They were able to get the ET tube in.
Terrific. Okay, why don't you proceed?
Absolutely. Let's see. So post-operative course, she did get VV ECMO specifically. Luckily, her O2 saturation did actually improve. On hospital day 12, though, she had a fever with rising leukocytosis and increasing vasopressor requirements. So she was initiated on broad-spectrum antibiotics. Despite that, though, she still was persistently febrile with persistent leukocytosis as well. And blood cultures at that point actually did return MDR, E. coli, and MSSA. And despite even broadening further to the big guns of meropenem, she wasn't improving. And so at this point, we were thinking to ourselves, shoot, does she have a leak going on into her abdomen? Does she have, what else could be going on? Well, what I did mention at the initial onset was after she was closed. When I say she was actually closed. There was no wound back. It was with staples. And unfortunately, this is what her abdominal wound looked like. And so the question that we had to face at this point was, would we take her to the CT scanner, or is this someone that you would just go straight to the OR with?
Okay, so let's go to Dr. Kassim. Sorry, sir. I think I missed you last time. I missed you last round.
It's okay. It's okay, doctor. Don't worry. So you were lucky to begin with. Then the luck ran out. That's how I would look at this case. And now you're looking at a wound. Looks horrible. And also you have all these bugs growing and their resistance to antibiotic, which is the modern conundrum. That's what's happening in a lot of hospitals in United States, I read. And I think at OHSU, they have instituted a very strict antibiotic management of patients with trauma especially. And because they have had something like this as well. On top of that, here in Portland, they have dedicated ECMO teams. There are 2 doctors who rotate between themselves and they're all set up to go within minutes and to institute ECMO when needed. And that is being practiced at Legacy Portland Hospital, I know of. Okay, now that you have a patient who is not doing well and the wound looks like CRAP, I think going to the CT scan is not that great idea. I think you need to do aggressive debridement of the wound, opening the abdomen to see what's going on behind the peritoneum there. And if there is a leak, take care of it and try to salvage the patient. Otherwise, this patient is going to die of sepsis.
Okay, Dr. Frisbee.
Yeah, I think he's right. I think Kasim is right. You know, you get to the point where what are you going to do in the CAT scanner? She needs to be opened and washed out, and that wound needs some wide debridement at this point. That's the only thing I would do.
Okay, Dr. Epstein.
A look is worth 1,000 scans. So I
Good one.
I would just go to the OR. You're going to have to debride, so you might as well open up because you got to go for the money, not the scan.
Yes, and Dr. Calderon.
Completely agree. That
Yeah.
wound needs to be washed out and debrided, and I need to look what is inside. Maybe there is a leak from any missed bowel injury, or there is a leak from the liver injury. I need to take a look inside. I mean, if anyone wants to do a CT scan of the patient, I'm not against, but that will be a trip to the CT scan on her way to the operating room. Yes, she needs to be taken to OR. And from the ID point of view, well, we need to consult ID physician the next steps in the antibiotic therapy. Maybe needs linezolid, tigecyclines, antifungals. No, thank you.
All right, and then Dr. Chu, so just remind me,
Yes, sir.
her status now, is she on pressors and she's
Yes. If I remember correctly, she was on 20 of levo, whereas after she had been on ECMO, she was actually okay. And then that's when her pressor requirement just increased over the next 1 to 2 days. So she's on Levophed, going up with vasopressin. And then she's persistently febrile up to like 102 to 103, every couple hours or so. And her leukocytosis, I believe at this point was going up from 12 to 20.
and her blood pressure?
Her blood pressure while on the Levophed of 20 was stabling out, but it was still softer in the 90s.
Yes. So, yeah, I agree with everyone else. The only reason to do a CAT scan is if you think it would pick up something subtle that you might miss during an exploration. You know, when I started as a resident, and I know Dr. Kasim and the older folks here, there was no CAT scan for the abdomen. The CAT scan in our day was the scalpel. So, you know, you can go straight to the OR, but you have to be careful to do a very thorough exploration. So, you know, you want to be sure that there's no gangrene, no fasciitis spreading laterally that you're going to miss without a CAT scan, but you should be able to detect it by manual palpation of the abdominal wall. You have to look at both kidneys, the perinephric spaces, the lesser sac, a really a classical, thorough abdominal exploration without missing anything, not just running the bowel, whatever. Because without that, she won't recover.
So, with the line of reasoning that, even if she had a bowel leak, we'd still be able to see that if we explored. We actually went ahead and explored. So we returned to the operating room for reopening of the laparotomy. And what ultimately we ended up finding was necrotic abdominal wall, as well as fascia. So, she was dealing with a necrotizing soft tissue infection. So we debrided all that we could. About 250 square centimeters of tissue was debrided. And then we also found that there was a pocket of pus, a large pocket of pus in her pelvis that we went ahead and was evacuated as well. So after thoroughly irrigating, though, we didn't see any signs of succus or any sort of leak. At this point, her bowel was pretty matted, or was becoming matted, and so we didn't want to take it apart too much. So we did what we thought was safe. But again, after thoroughly irrigating, we didn't see any more signs of succus. So we went ahead and left it up there and took her back to the ICU. Give me 1 second here. So fortunately, after the next couple of days of, she went back to the operating room once, and we were able to, at that point, close her with the bridging vicryl mesh. There were no signs of succus or pus at that point. She actually was cleaned up pretty well. Her pressure requirements were actually down to 3 at the time of the take back, I believe. And the rest of her course was fortunately relatively uneventful. She did require tracheostomy, but was eventually decannulated from ECMO, and she was eventually discharged after a prolonged hospital course to acute rehab. Currently, I want to say about a year later, well, I don't think I'm cheating by going this far ahead, but a year later, we were able to reverse her ostomy, and she's actually doing really well now, fortunately. And this is a picture that she said she would love to share with everybody who could learn from the story.
Okay, well, great save, excellent case, and par for the course with these kinds of injuries, expected complications. So, final comments, Dr. Frisbee.
Well, I think it's well done. It's like a plane crash. If you can walk away from it, that's a good landing. And this one was good. This was very good.
Yeah, it was like that collision yesterday in the air show. You see the planes colliding and the four pilots parachuting out to safety. Very good. Okay, Dr. Kassim.
Well, when you have a surgeon like Dr. Paula Ferrada, you can't go wrong. I think she's absolutely a fabulous surgeon, and great save, great save. And this lady would have died in another institution, I bet. I think I take my hat off to Dr. Ferrada.
Yes, and Dr. Ferrada saved the patient by training up Dr. Chu and his colleague, Dr. Sarah, where's Dr. O'Berry. So there you go. All right, so Dr. Calderon.
Yes, good save. The clues for that is the good job of Dr. David Chu and the availability of the ECMO. Otherwise, the patient would have died earlier of the respiratory distress. Yes. Well, that's all I have to say by now.
Yes, and Dr. Epstein.
Great doctors. They had just the right timing for everything.
Yes, and what I would say, I would add 1 point, and that's from experience in Africa, where there's sometimes no running water, no electricity, and that when you're in a case like this and you decide to close the abdomen, just leave the skin and sub-Q open. I don't know. Maybe she would have gotten the same synergistic fasciitis, but and you're shaking your head, Dr. Chu. So that's a good thing to remember. Just leave the incision open. It'll heal much faster, especially if you have a wound vac. Just put that in, take it out after a few days, change it, and I think, and then if the patient gets synergistic fasciitis despite that, okay, well, then there was nothing more you could have done to prevent it. Let me just ask you, how much abdominal wall did you have to resect?
The actual abdominal wall, it was pretty deep. Granted, so admittedly, I wasn't actually in that part of the case. That part I had to take and sign out. But I would say it was a good chunk. It was definitely to the point where I just couldn't even imagine bringing those fascial edges together, honestly speaking.
So how did you eventually close the abdomen primarily? Did you have to reconstruct with plastic surgery?
Oh, sorry. Yes, that's your question. Honestly, if I remember correctly, we closed with a vicryl mesh on top of it. We just placed a wound vac, and we were very fortunate that it started to granulate over. So even though she's dealing with a ventral wall hernia, the soft tissue closed pretty nicely over it, just with
Okay.
the wound vac. So it was small enough for the actual granulation tissue to be able to connect.
Yeah, and I think sometimes if you leave these wounds open, you avoid that part that the because it just gets away from you the necrosis of the musculofascial layer. But anyway, so that's a good just you remember that. So for the
Yes,
rest of
sir.
your career, you're not going to close another one primarily, I bet. So there you go. All
Well,
right, and it was a great save. It was a great. But it's a shame that it was necessary to begin with. That there's this interpersonal violence, but at least you were there to help her out and her son. Okay. All right. Is that this case? You ready for the second case?
Yeah, and I think Sarah just said that she was in a good spot. So I'll keep sharing. Then, Sarah, if you want to test out your mic and make sure you can talk.
All right. Hi, can everyone hear me?
Perfect.
All right.
Yes.
Hi, I'm Sarah O'Berry. I am a PGY3 surgery resident here at Inova. I'm going to be presenting a second case for you guys. I have no disclosures.
Dr. O'Berry, I did make you a co-host, so if you did want to share your
Okay.
camera,
Okay,
you have the
great.
option.
Thank
Yeah.
you.
Mhm.
Okay, so this is a 49-year-old male who presents as a modified trauma activation, which is our lower level of trauma activation, after an unwitnessed fall down 5 to 6 steps while intoxicated. His airway was intact. He had equal breath sounds bilaterally and was hemodynamically normal in the trauma bay. He did have a GCS of 13 with points off for verbal and motor. FAST and chest x-ray were both normal, and physical exam was significant for intoxication, bleeding from his left ear canal, and moving all 4 extremities. So as for the next steps, is there any indication for intubation or the OR, or is it safe to proceed to the CT scanner?
Okay. I think this is a bit straightforward, reasonably straightforward. So we'll go to, let's start with Dr. Calderon.
Yes, looks like another intoxicated man who fell off and might hit his head, but we have to finish our primary service. I will still do the chest X-ray and the ultrasound, and he needs to go to the CT scan to take a look inside the brain. Be very vigilant. He doesn't need intubation at this time, but let's be very vigilant because the GCS can fall very quickly if we don't pay attention. Okay. Thank you.
Okay, Dr. Qasim.
I would do a thorough neurological examination first, just for documentation, and then I would not intubate this patient, but I would take him to the CT scanner for a pan scan to see if I'm missing anything or if he's got just intracranial problem.
Okay, let's see, Dr. Frisbee.
I think he belongs in the CAT scanner. What's the rule about external auditory bleeding after a trauma? That's where he's got to go.
Okay, Dr. Epstein. Dr. Epstein, not there. Dr. Qasim, did I come to you yet?
Oh,
Yes,
I'm
you
here.
did.
I'm
You did.
sorry.
Okay, very
I'm
good. There
back.
you go. It's my short-term memory. It's going already. Okay.
I would do the
Yeah.
same. I would do the same.
Yeah.
Pan scan head.
Yeah.
It's sort of obvious, but this is how trauma started all those many years ago because you just ignored the rest, and maybe spleen is there and you don't know it yet.
Right. Yeah. So that's straightforward. The primary survey pretty straightforward. And bleeding from the ear, so you need to rule out basal skull fracture, whatever. So yeah. So I think we're unanimous.
Okay.
Okay, so we did take him to the CT scanner. CT head is shown here. Showed a left occipital skull fracture, left posterior fossa epidural hemorrhage, bilateral subdural hemorrhages, and bifrontal contusions with subarachnoid hemorrhages. Unfortunately, as we were getting the head portion of the scan, he became agitated with a decline in GCS to 7. His pupils were still reactive. He still had intact reflexes, which brings me to my next discussion point. With this sudden decline in GCS, how would you proceed?
Okay, so Dr. Qasim.
Well, now things are changing, and you are mandated to intubate this patient according to ATLS. You have to intubate this patient, and then go from there.
Okay, Dr. Frisbee.
Yeah, that's correct. Anything below 8, he needs it.
Yep. Dr. Epstein.
OR,
OR for
craniotomy, call the neurosurgeons. Did we not see air within the cranial vault there on the scan?
Here, let me see if I can go back. Sorry about it.
I thought I saw some air there. Right.
Okay.
There's a bleed there as well.
Yeah. So okay, but no midline shift, no
No
effacement.
midline shift. But
No
obviously intubation by ATLS.
Exactly. And Dr. O'Berry, the vital signs at this point?
Vitals were still all hemodynamically normal.
Okay. All right. Yeah. So I agree calling the neurosurgeons, but the problem is looking, from my non-neurosurgical expertise, it doesn't look like there's something obvious that you can fix immediately. So, but I would still call the neurosurgeons and on the way to the OR without putting him to sleep until they get there and look at the scans and all that. Okay, Dr. O'Berry, you can proceed.
Okay. So we took him back to the trauma bay and intubated him for airway protection at that point. Once he was deemed to be stable, we took him back to the CT scanner and repeated his CT head, which showed an increased left posterior fossa hemorrhage, as shown here. We were able to complete his pan scan at that time, which was negative for any other injuries. So with this worsening with the epidural hemorrhage, how would you proceed?
Okay, so epidural hemorrhage. Okay, so Dr. Epstein.
Again, are his pupils blown? Is there
No,
a
pupils
reason?
are still equal and reactive.
Is he being treated with hyperosmola, mannitol, or whatever is used there, and hyperventilation? If his pupils are not, then there is no reason to hyperventilate. I would see what the neurosurgeons want to do and see if they want to put in a shunt, not a shunt, a pressure monitor.
Okay, Dr. Calderon.
Well, many people don't know, but I did have a neurosurgical background. In the first CT scan, well, the patient just needed to be intubated, taken to the ICU, and neurosurgeon must already be on touch, not for necessary for a surgical management, but for the initial neurologic specialty list assessment and the follow-up. With that follow-up CT scan, excuse me, Dr. Sarah, how many hours after did you do this new CT?
The new CT was immediate. He had a decline in GCS. We took him
Almost
to the trauma bay, intubated,
Oh,
and immediately went back.
well, that's different. With the increasing size of that posterior fossa bleeding, the patient is in greater risk of brain herniation. So it really needs to be taken to the operating room. So the neurosurgeon must be updated with these new findings. The patient needs to go to the OR for craniectomy. Okay, thank you.
Okay, Dr. Qasim.
Having very little experience in this type of injury, I will get advice from the neurosurgical team and let them decide what they want to do.
Yes. Okay. And so this seems like just a classic case of an epidural hematoma, basically the injury, the lucid interval, and sudden deterioration. But it's in an unusual place in the posterior fossa. But I agree with everyone else. The neurosurgeon has to be on the case. You would have called him, but it happened immediately after the first CAT scan. You didn't have time to call the neurosurgeon because you did the CT and then he deteriorated. So just one of those things. All right, Dr. O'Barry, go ahead.
Okay, so we did consult neurosurgery. They placed a right frontal EVD for ICP monitoring. The opening pressure was 19, and we started Keppra for seizure prophylaxis. So on hospital day 1, his intracranial pressures were elevated to 26. He had an exam of GCS3T. We initiated our hospital TBI protocol, and per that protocol, initiated fentanyl and propofol drips. We also required 2 boluses of Versed for his elevated ICPs. We noticed that his Aspen was still in place despite the isolated TBI on imaging, and he had been moving all 4 extremities in the trauma bay. Is there anyone who would leave the Aspen in place, or would everyone agree on removing it?
Well, I think we can answer that if you tell us what an aspen is.
Oh, sorry, an Aspen is a C-collar.
Okay, C-collar. Okay. Well, okay, so why don't we go around again? We'll start at the top. Dr. Kassim.
Get rid of it.
Sorry?
Get rid of the C-collar.
Okay, Dr. Epstein.
I'm going to assume that you had the CT of the neck and it was negative.
Yeah.
Correct, yes.
And if that's the case, get rid of the C-collar.
Okay. Yes, Dr. Frisbee.
Yeah, I agree. If you've
Yeah.
got a clearance, if you've got C-spine clearance,
Yeah.
you don't need any more interference.
Yeah. Dr. Epstein.
I would get rid of the collar,
Yeah.
assuming negative scan.
Right.
Mhm.
Either asking very easy questions, Dr. O'Barry, or you have a plot twist for us. So we'll see. Why don't you proceed?
All right, so we did remove the C-collar and his ICPs improved. On hospital day 2, however, we were maxed out on our fentanyl and propofol drips. His sodium was 143, osmoles were 295. So at this point, would you consider hyperosmolar therapy? If so, what kinds, what methods, what are your sodium goals for him?
All right. Let's start with Dr. Kassim. Not to put you on the spot.
Well, again, having very little experience in managing cases like this, I defer this to my neurosurgeon and the ICU doctors who are very good in managing cases like this.
Right, and to think that this is what general surgical residents are learning these days. My goodness. Okay, Dr. Calderon, you have the most neurosurgical experience of anyone here. Why don't you give us your opinion?
Yes, the answer is yes to the hypertonics or mannitol, but it will make any bleeding to increase. So I still need that. He needs the suboccipital craniectomy and evacuation of hematoma, but that's up to your neurosurgeon. I cannot push him.
Right, and okay, and then so you only have the 2 CAT scans, right? You didn't repeat it to see what the hematoma is doing or any of that, right?
No, at this point, we're about 48 hours out. So we
Okay.
would have obtained our 24-hour CT scan, which I believe was stable.
So that was the 3rd CT, is that right?
Yes, yes, sir.
Okay, and so there's no change in the size of the hematoma. Okay, all right. And then if somebody can explain to us, the hyperosmolar therapy is kind of like mannitol therapy, isn't it, to decrease intracranial pressure as a bridge to something else, or do I have that wrong?
Personally, I think the neurosurgeons would go higher. They would go to an osmo of 305 and let the sodium go to 150, 155 and reassess. You have to reassess their neurologic status every several hours as well. So you're going to have to cut back on the propofol And then if things don't get better, I'm assuming the last scan did not show a worsening of the bleed.
Correct.
So then I guess continue, not I guess, I would, if it was me and no neurosurgeon, and let the osmo increase to 305 and the sodium to 150 to 155. And I'm not sure what the literature says, whether it's 23% or mannitol these days.
Okay, and then that could be a primary treatment in itself. Is that right? Without buying time to do something more definitive. Is that right, Dr. Epstein?
It could be.
Okay.
You have to look to see if they're stable. What is the intracranial pressure?
Yes. Okay. All right. Okay, Dr. O'Berry.
Yes, so we were giving him 3% saline. However, by hospital day 5, his ICPs were peaking at 39. We had maxed him out on fentanyl, propofol, and Versed drips. At this point, his sodium was 145, osmols were 305. So at this point, how would you proceed?
Okay, so let me let myself go first, and then we'll go around. You know, I'm not very smart, but I have a burr hole here, Kit, and a CAT scan. If I saw that and you weren't getting better, personally, I would pick up the phone and call somebody just to be sure. But I would be tempted to put a burr hole right over that hematoma and then evacuate it. I mean, you've tried everything else, and he's deteriorated. But that's just me. But and then how about let's see, Dr. Calderon?
I think I have already answered this. I will call again the neurosurgeon. Yes, Burhole is not enough.
It's not enough. Okay, right.
No.
But I'm talking about here, where it's way out in the desert, and there's no one nearby. But okay, and Dr. Epstein.
If you, at this point, the neurosurgeon has to make a decision whether he's going to do a craniectomy or continue with this therapeutic. And this therapeutic is not very good with his intracranial pressure of you said 39 if I saw this before. So now out in the desert, that becomes more difficult. I would like to hear what everybody else has to say from the desert.
There you go. Right. Okay, Dr. Frisbee.
Down here at Emory, the surgical residents are being taught exactly what Calderon said. Burr holes just are insufficient. So they do partial craniectomy and obviously wait for the pressure to normalize. But the only experience I have is with a burr hole, based on the fact that I was trained a long time ago. But that's what I would do. Call
Okay,
them up,
go ahead.
call him up and get the neurosurgeon to give you his honest opinion.
Yeah, Dr. Kassim.
I agree with Dr. Frisbee.
Yes. Okay. Yeah, and right. Currently, the trend is like for diffuse brain swelling, diffuse axonal injury, or the neurosurgeons do emphasize a very extensive craniectomy to let the brain swell. It mushrooms fungates out of the craniectomy. But in an acute emergency with a limited hematoma, that's the least you can do. But anyway, why don't you tell us what happened next?
Okay, so we were giving pushes of 3% saline, mannitol, and vecuronium. At this point, we also added a levofed due to hypotension, which helped to optimize his cerebral perfusion pressure. And all of this helped to bring down his ICPs to a manageable level. However, he did become febrile to 101.5, managed with Tylenol, cooling blankets, and ice packs. So with this new fever, would you think it's more likely due to infection or to neurostorming?
Okay, quickly, let's go around. Dr. Epstein.
Well, you have to assume it's neurostorming and you have to assume it's an infection. So you need to start to treat both. Perhaps we should mention you have to have oxygen, blood pressure, and now fever is not good for brain swelling. So I think you have to look at cooling them down and look for infection.
Dr. Calderon.
Well, Dr. Epstein already said it all. Must be a neurostorming, but you have to, of course, you're going to make a blood cultures, all your cultures you want, give antibiotics, and try to take the temperature down because it increases the neuro damage.
Yes. Okay. Dr. Kassem.
I agree with the previous two speakers.
Yeah. And Dr. Frisbee.
Oh yeah, that's got to be the way to go.
Yeah. So, yeah, I would say that suddenly a patient with head trauma becomes febrile and hypotensive. So I would be, I would have to rule out the infection. So, how many days out now from his injury?
This is only about 5 days.
5 days. So, it's probably an aspiration pneumonia. You'd expect that in this clinical picture. And so I would quickly do a chest X-ray, work them up for, get some blood cultures, work them up for an infectious source. I would likely start, if there's any suggestion of pneumonia, I would start antibiotics to treat it, and then also treat them for the neurostorming. Okay.
Okay. Yes, so we were given the timing from his initial presentation, the fever of 101, the hypotension on pressors. We did a Brock and BAL, and cultures were growing H flu. So he was treated for that, and the fever resolved. So the remainder of his hospital course is shown here. He underwent trach and peg placement on hospital day 16, at which time he was a GCS of 9. By hospital day 33, his trach was decannulated and he was a GCS of 11T. On day 34, he was discharged to acute rehab on room air, tolerating a diet with a GCS of 14. And 2 weeks later, he was able to go home.
Okay, very good case. So we have time for closing comments. Let's start with Dr. Frisbee.
What was the patient eating just before you discharged him?
He was eating, I believe it was soft foods.
Okay. Was he making good sense?
He was a little confused, but mostly with it.
All right. Well, that's a good case. It's a kind of a really sort of out of my wheelhouse, but it's a very, very good case. You did good work. Thanks for sharing it with us.
Yes, thank you both for having me.
Okay, Dr. Epstein.
This is this is perfect timing for each intervention. And the neurosurgeons were obviously right in not operating because of the outcome. But there's always this controversy. The trauma surgeon wants the operation because they're getting worse, and the neurosurgeon says, I'm not coming in at 3 a.m. to do the case. And he was right, or she. So great outcome.
Yes, Dr. Kassem.
Well, it just goes to show when you have a bunch of good doctors like you have at your institution, the results speak for itself. Fantastic case. If I was a neurosurgery resident, I would take this I would make a note of this and try to get a position there so I can learn more.
Yes, Dr. Calderon.
Yes, I wanted to ask to Sarah, before discharging the patient, I know he was on GCS 14, but any motor deficit, or do we have a new CT scan that shows the relief of the bleeding or any new infarctions? What happened?
I don't believe we have any other scans, but he had no motor sensory deficits.
Oh, nice. Well,
Yes, very good. So
yes.
there, it's a
Thank
very illuminating case here. This patient got all these hyperosmolar interventions and the monitoring, and he needed the craniectomy like a hole in the head. So that was, it was a very very instructive case, and it was another great save. And it's these two cases. It just shows some of the misery that people endure, and I imagine this wasn't a one-off, that maybe he needs to go to chronic rehab to prevent this from happening again. Is that did the social workers get involved and take care of him?
Yes, we had our social workers involved, and we had our addiction team helping him as well.
Yeah,
May
'cause-
I ask Dr. O'Barry a question, please?
sure.
Do you rotate with neurosurgery at all during your years?
Neurosurgery joins us in our trauma ICU and our vascular teams. Otherwise, we don't personally rotate on any neurosurgical rotations.
Because my suggestion would be for those residents going elsewhere, perhaps they ought to scrub in on craniectomies and know how to do them, not as an everyday thing, but if you're in the desert and you happen to have a CAT scan and no neurosurgeon, it might be nice to know how to do it, or a burr hole.
There you go. And in our day, Dr. Epstein, neurosurgery was always an option as an elective, for in our first year to get some exposure.
Yeah,
Right?
I didn't have the option.
Okay, all right, I did for
I
whatever.
didn't
I can
either.
mention in Peru is 1 month obligatory rotation.
Yeah, it was 2 months for me during the first year, and it was very helpful. And it's good to have a broad exposure, especially when you're going to be doing trauma critical care surgery. You need to have a very broad exposure to all of these specialties. But you have access to the experts, so that was very good. So two excellent cases. Dr. Ferrata was not there, but she'll watch the video. She can be proud, and she trained you both well. Very good. All right. So Kevin,
Yeah.
put the code up for the
Yeah,
CM.
the CME information's in the chat. I'll leave it there for a few more minutes. And just reminder that next Monday there won't be a meeting because it is Memorial Day. So, next Monday. Yeah.
Okay,
All
I
right,
forgot.
Dr. O'Barry and Dr. Chu, thank you very much. Panelists, thank you very much. Have a great week and the rest of your day.
Thanks,
you.
Kevin.
Bye-bye.
Goodbye.